Usually when you look at an x-ray of a broken bone, you expect to see, like, a snapped quake.
Right, just a clean, jagged break.
Yeah, exactly. And the doctor points at that harsh white line and says, there it is.
It's very binary. I mean, it's either broken or it's not broken.
But then you look at a pediatric x-ray, and sometimes the bone isn't snapped at all. It's just bent, like a piece of warm licorice.
It really defies everything we adults assume about structural integrity, doesn't it?
It completely does.
Yeah.
And if you are a nursing student listening to this right now, gearing up for your ATI RN Pediatric Nursing Proctored exam, that bend, don't break physiology completely dictates how you will treat your patients.
Oh, absolutely. Because, you cannot treat a child like a miniature adult.
Right.
Their structural foundation, the way their bodies respond to trauma, and even how their nerves communicate with their muscles are entirely unique.
Okay, let's unpack this. Because looking at your dense stack of notes covering pediatric musculoskeletal and neuromusculoskeletal disorders, I mean, the sheer volume of information could easily cause info overload.
It's a lot to take in at once.
It is. We have got chapters 27, 28, and 29, fractures, congenital defects, and chronic neural conditions. So we are going to extract the highest yield, most testable nuggets from this material. But more importantly, we are going to make them make logical sense.
Yeah, and if we connect this to the bigger picture, mastering these topics is not about rote memorization.
Thank goodness.
Right. Once you understand the why behind pediatric body mechanics, the specific nursing interventions simply become, well, logical next steps.
So let's start with acute injuries, fractures. Because figuring out how healthy pediatric bones break and heal sets the foundation for the complex congenital conditions we will look at later. I saw a fact in your notes that stood out.
Oh, which one?
That a child's bone heals significantly faster than an adult's. Mechanically, why is that?
Well, it really comes down to a structure called the periosteum.
The periosteum.
Yeah, it's the dense layer of vascular connective tissue that envelops the bones. And in children, this tissue is incredibly thick and possesses a massive, rich blood supply.
Yeah.
So it acts almost like a biological 3D printer for bone repair.
Wait, really? A 3D printer?
Pretty much. It delivers a huge influx of nutrients and osteoblasts, the cells that build bone, directly to the injury site.
So if you go back to the idea of a child's bone being like a young green tree branch,
yeah,
if you try to snap a young sapling, it does not break cleanly in two.
Right, it bends.
Yeah, it bends, it splinters a bit on one side, but the structure largely holds together.
That is the perfect visual for the specific pediatric fractures you will encounter in clinical practice. Because of that thick periosteum and pliable bone matrix, a child can experience what's called a plastic deformation.
Plastic deformation.
Yes, meaning the bone can literally bend up to 45 degrees without technically fracturing.
45 degrees without breaking. That is wild.
It is. And then you have the buccal fracture, which is also known as a torus fracture.
How does that one work?
Imagine pushing down hard on a drinking straw. Instead of snapping, it compresses and bulges out at the weak point. So that's a compression injury.
Oh, I see.
And finally, the green stick fracture, which perfectly aligns with your tree branch analogy. One side of the bone fractures and the other side simply bends.
Okay, so if a child comes in with a green stick fracture near the joint, do they just put a standard cast on it and let that rapid healing take over?
Well, not if it involves the epiphyseal plate.
The growth plate.
Exactly. This is the danger zone. The epiphyseal plate is the cartilaginous area at the end of long bones where growth actually occurs. So if a fracture disrupts that plate, you cannot just cast it and hope for the best.
Because it messes with their growth.
Precisely. It requires incredibly careful monitoring and often precise surgical intervention. If it heals incorrectly, that specific bone stops growing while the opposite limb continues. The child could end up with a severe leg length discrepancy.
Wow, okay. That immediately changes the stakes.
Let's talk about the clinical reality of casting, though. Imagine you are the nurse, and the provider just applied a wet plaster cast to a squirmy toddler's leg.
A very common scenario.
Right, and we want to get them dry and comfortable as fast as possible. Why can't we just grab a warm hairdryer or a heat lamp to speed up the process?
It's a tempting shortcut, I know, but it is absolutely contraindicated for two reasons. First, plaster generates its own heat as it cures.
It does.
Yeah, it is an exothermic chemical reaction. So adding external heat from a lamp or hairdryer traps that energy and can literally inflict thermal burns on the child's skin underneath.
I hadn't even thought about the chemical reaction. That's terrifying.
It is. And furthermore, artificial heat dries the outer shell of the cast rapidly while the inside remains damp and soft.
Oh, so it's uneven.
Right. This completely compromises the structural integrity, allowing the cast to warp.
And warping leads to my next question. Your notes emphatically state that you must handle a wet plaster cast only with the palms of your hands, never your fingertips. Yes, that is so important for the exam in real life. Your fingertips exert focused, localized pressure. If you grip a wet cast with your fingers, you create subtle indentations in the plaster.
Like little dimples.
Exactly. And once the cast fully hardens, those internal dimples become rigid spikes that press directly into the child's tissue.
Oh, ouch.
Right. And because the child cannot scratch or relieve that pressure, it quickly develops into a severe pressure ulcer hidden beneath the cast.
Now, whether the patient is in a cast or just sustained a traumatic injury, the most terrifying complication in this entire section is compartment syndrome.
Absolutely. It's an emergency.
I know ischemia means a lack of blood flow, but mechanically, how does a tight cast or a swollen muscle actually lead to tissue death?
It is all about the fascia.
Okay.
The muscles in your arms and legs are grouped together into compartments, and these compartments are encased by a tough, fibrous web of connective tissue called fascia. And the thing you have to remember is fascia does not stretch at all.
So it is like a thick leather casing around the muscle.
Exactly. When a bone breaks, the surrounding tissue swells and bleeds. But because the fascia cannot expand to accommodate that extra fluid, the pressure inside the compartment skyrockets.
And if they have a cast on?
Then you have a second unyielding layer. The building pressure has nowhere to go but inward, where it violently compresses the blood vessels and nerves.
It is strangling the limb from the inside out.
That's exactly what's happening. Neuromuscular ischemia sets in, blood cannot get to the tissue, and waste products cannot leave.
So what happens if you miss it?
If you do not relieve that pressure rapidly, irreversible nerve damage and tissue death occur in a matter of hours.
Hours. Wow.
Yeah. The treatment is usually bivalving the cast, cutting it completely in half down both sides like a clamshell to release the pressure, or a fasciotomy where a surgeon physically slices the fascia open.
To catch this early, the nurse has to memorize the 5 Ps of neurovascular assessment. What are we looking for?
Well, pain is the most critical early indicator, specifically intense, agonizing pain that is entirely out of proportion to the initial injury.
Okay, out of proportion pain.
Crucially, this pain is not relieved by IV analgesics or by elevating the limb. If a child is screaming in agony after receiving a dose of morphine, your alarm bells should be ringing.
What are the other 4 Ps?
Paresthesia, which is the early tingling or pins and needles sensation as the nerves get choked. Then pulselessness distal to the fracture, though I must warn you, this is a very late and ominous sign.
So if the pulse is gone, it's already bad.
Very bad. If you lose the pulse, severe damage has already occurred. The next is paralysis, or the inability to wiggle the toes or fingers. And finally, pale, cold skin, indicating that capillary perfusion has completely stopped.
Okay, got it. Now, imagine you walk into your patient's room. They are in skeletal traction for a severe femur fracture. They have metal pins surgically drilled through their bone, attached to a complex system of ropes and heavy weights hanging off the end of the bed.
A very intense setup.
Yeah. And the child has slid down toward the footboard. Can you just lift the weights for 2 seconds, slide the kid up, and gently set the weights back down?
Absolutely not.
Never.
Never. You never remove or lift the weights to reposition a client in skeletal traction. The traction is the treatment.
Okay.
Those weights are the only force actively fighting the massive muscles of the thigh, which desperately want to spasm and contract around the broken bone.
Oh, so if you lift them.
If you release the tension even for a moment, the muscles violently spasm, driving the jagged bone ends into the surrounding tissue and causing excruciating pain.
Yikes. Okay.
You must use the trapeze bar and assistance to move the child while ensuring the weights always hang completely freely.
Makes total sense. So we have just looked at how healthy bones repair themselves when subjected to outside trauma. But what happens when the blueprint itself is flawed from the moment of conception?
That changes the nursing approach entirely.
Yeah, let's transition into Chapter 28, Congenital Structural Anomalies.
Right. This requires a shift from acute trauma management to long-term developmental correction.
Here's where it gets really interesting. Developmental dysplasia of the hip, or DDH. Essentially, the hip joint didn't form properly in utero. The socket, the acetabulum, is too shallow, so the ball of the femur slips out.
Correct.
But I read about checking the skin folds on an infant's thighs during an assessment. Why would a hip problem cause extra wrinkles on the leg?
It is an issue of displacement. When the head of the femur isn't anchored down in the hip socket, the powerful muscles of the leg pull the femur upward, displacing it toward the pelvis.
Oh, so the bone moves up.
Right. Because the underlying bone has essentially slid upward, all the skin and fat of the thigh bunches up like an accordion.
That is such a vivid image.
Therefore, if you lay the baby on their stomach, you will see extra asymmetrical skin folds on the back of the affected thigh and buttocks.
And the provider will perform 2 specific physical tests to confirm this, right? The Ortolani and the Marlowe maneuvers. I always get them confused. How do they mechanically work?
Think of it sequentially. The Barlow test is used to discover if a seemingly normal hip is unstable and actually can be dislocated. Okay.
The provider holds the infant's knees, adducts the hips by bringing the thighs together, and pushes backward. If the hip is unstable, the femoral head will pop out.
So Barlow tests if it goes back and out?
Correct. The Ortolani test is then used to reduce or fix the dislocation. The provider abducts the hips, spreading the infant's knees outward like a frog, and gently lifts.
And what happens then?
If the hip was dislocated, you will hear and feel a distinct, palpable clunk as the femoral head physically drops back into the acetabulum.
You literally feel a clunk.
You do.
Okay, so if the infant is diagnosed with DDH, the standard treatment under 6 months is the Pavlik harness. As a nurse, you are educating the parents on how to use this complex system of straps. What is the most critical directive?
The parents must never adjust the straps themselves.
Never. Not even a little bit.
Not at all. Only the healthcare provider alters the tension. The harness is meticulously calibrated to hold the infant's hips in a state of constant abduction and flexion.
Okay, so it keeps them in that frog position. Yes. This constant positioning is what forces the shallow hip socket to deepen and mold itself securely around the femoral head as the baby grows. If a parent loosens a strap because the baby seems fussy, the joint slips out and the remodeling process completely stops.
Okay, speaking of the body failing to build strong structures, I want to ask you about osteogenesis imperfecta, commonly known as brittle bone disease.
A very challenging condition.
Yeah, these children lack the proper scaffolding for their bones, leading to multiple fractures from something as simple as a diaper change. But there is a weird clinical finding in the notes.
The eyes, right?
Yes. These children often have a blue or gray tint to the sclera, the whites of their eyes. How does brittle bone disease change the color of your eyes?
Well, what's fascinating here is that osteogenesis imperfecta is not strictly a bone disease. I mean, it is a systemic defect in the production of collagen.
Collagen.
Yeah. Collagen is the tough, fibrous protein that acts as the steel rebar inside the concrete of your bones. But collagen is also the primary structural component of the sclera in the eye.
So their eyes are literally built with defective materials.
Yes. Because the collagen is faulty, the sclera becomes abnormally thin and translucent. What you're actually seeing is the dark, heavily pigmented layer of the eye, the choroid showing right through the thin white sclera, which creates that characteristic bluish-gray tint.
That is incredible. Okay, I want to look at one more structural issue here. Leg calf Perthes disease.
Okay.
The notes define it as aseptic necrosis of the femoral head. Aseptic means there is no infection. The blood supply to the top of the femur just temporarily stops, and the bone tissue literally begins to die and crumble.
Yes.
That sounds like a 10 out of 10 on the pain scale.
You would certainly expect it to be a sudden, agonizing event, but surprisingly, the classic presentation of leg calf Perthes is a slow, insidious, and often completely painless intermittent limp.
Wait, painless? How is dying bone painless?
Well, because it happens so gradually, the blood supply diminishes over time, and the child's highly adaptable body tries to compensate. They might complain of mild stiffness or a vague ache in the knee, which is referred pain from the hip, but it rarely presents as acute trauma.
So what's the treatment?
The treatment involves keeping the crumbling femoral head perfectly seated in the hip socket using braces or casts for months or years, while the body slowly regenerates a new blood supply and rebuilds the bone from scratch.
Since we are discussing braces, we have to mention scoliosis, the lateral curvature of the spine. If a teenager is prescribed a hard plastic TLSO brace, The nursing care seems much more psychological than physical.
It really is, because the physical reality of the brace dictates the psychological burden. That hard, restrictive shell must be worn for 23 hours a day to prevent the curve from worsening.
23 hours.
They only take it off to shower. Imagine being a young adolescent, already hyper-aware of your body image, and having to wear rigid armor under your clothes all day at school. Non-compliance is incredibly high.
I can imagine. And if the curve progresses past 45 degrees, they require a massive spinal fusion surgery. Post-op, the nursing notes mention a very specific way to move the patient called log rolling. Why can't they just scoot themselves over in bed?
Well, during a spinal fusion, the surgeon has essentially turned the flexible spine into a single, rigid cylinder of metal rods and bone grafts.
Right.
If the patient twists their shoulders while their hips stay flat, they create immense torque on that freshly fused spine, which can shatter the bone grafts or damage the spinal cord itself.
Oh, so no twisting whatsoever.
None. Log rolling requires multiple nurses to turn the patient's entire body as one perfectly straight unit, like rolling a log, so the spine never twists.
Got it. Okay, up until now, we have been dealing with the hardware of the body. Bones breaking, joints forming poorly, spines curving. But let's shift to Chapter 29, Chronic Neuromusculoskeletal Disorders.
This is a totally different ballgame.
Yeah, in these cases, the bones might be structurally perfect, but the brain's communication system, the signals traveling down the spinal cord to the muscles, is fundamentally broken.
Right. The structural hardware is fine, but the command center and the electrical pathways are misfiring.
Let's start with a high-stakes delivery room scenario. Spina bifida. Specifically, a newborn with a myelomeningocele. That is a massive medical term. What exactly are we looking at?
A myelomeningocele is the most severe form of spina bifida. During embryonic development, the neural tube, which becomes the brain and spinal cord, fails to zip entirely closed.
So it's an opening in the back.
Yes. The baby is born with a visible, fluid-filled sac protruding from their back. And it doesn't just contain spinal fluid. The sac actually contains a portion of the raw spinal cord and the surrounding nerve roots exposed outside the body.
That sounds incredibly fragile. What is the immediate nursing priority?
Absolute protection of that sac from drying out or rupture.
Because of infection.
Exactly. If that thin membrane tears, pathogens have a direct, open highway straight into the central nervous system, leading to lethal meningitis.
Wow.
So you must immediately cover it with a sterile, moist, non-adhering dressing soaked in 0.9% normal saline. And you keep the baby strictly prone on their stomach with their hips flexed and legs abducted to reduce any tension on the skin covering the defect.
Now, I saw a major red flag in the notes regarding spina bifida patients and severe allergies. They are incredibly prone to latex allergies. Why this specific population?
It is a consequence of their required medical care. Because the spinal cord is damaged, these infants almost universally suffer from neurogenic bladders.
Meaning they can't pee on their own?
Right. They cannot urinate normally. From the day they are born, they undergo frequent daily urinary catheterizations and multiple surgeries.
So and those use latex.
Exactly. This massive repeated exposure of latex to their internal mucous membranes sensitizes their immune system, leading to severe, life-threatening latex allergies.
But the truly bizarre part is the cross-reactivity with food. I see here that these patients need to avoid bananas, avocados, kiwi, and chestnuts. How does a rubber glove allergy translate to a banana allergy?
It is an incredible botanical link. Natural rubber latex is derived from the sap of a specific tree, and the proteins found in that latex sap are structurally almost identical to the proteins found in certain fruits, like bananas and kiwis.
No way.
Yeah. When the highly sensitized immune system of a spina bifida patient detects a banana protein, it mistakes it for a massive dose of latex and launches a systemic attack, potentially causing anaphylaxis.
That is just wild. Let's move to cerebral palsy, or CP. The notes emphasize that this is a non-progressive impairment of motor function, usually caused by an oxygen deprivation injury to the brain around the time of birth.
Correct. Non-progressive is the key word.
But if the brain damage is done and non-progressive, why do the physical symptoms seem to get worse as the child grows?
That is a crucial distinction for your exam. The actual lesion or damage in the brain does not expand or worsen over time. However, the manifestations of that damage become more obvious.
How so?
Think of the healthy brain as having two systems for movement. The gas pedal, which sends signals telling the muscles to contract, and the brakes, which send inhibitory signals telling the muscles to relax.
Okay, gas and brakes.
In spastic cerebral palsy, the anoxic injury damaged the brakes. The spinal cord is constantly firing signals telling the muscles to tighten, but the brain cannot send the signal to stop.
Oh, so they're just constantly tense.
Right. The child develops rigid spastic posturing. As the child's bones grow longer, those constantly tight muscles act like thick rubber bands, pulling the joints into severe, painful contractures.
To manage that severe spasticity, the primary medication listed is baclofen. How does it work?
Baclofen is a centrally acting skeletal muscle relaxant. It essentially acts as an artificial brake. It works directly at the level of the spinal cord to forcefully inhibit the transmission of those excessive motor reflexes, finally allowing the muscles to relax.
Okay, so contrast the non-progressive nature of cerebral palsy with muscular dystrophy, specifically Duchenne muscular dystrophy, which absolutely is progressive.
Very progressive.
It primarily affects boys, starting around age 3. The notes say it is caused by the absence of a protein called dystrophin. What does dystrophin actually do in a healthy muscle?
Dystrophin acts like a microscopic shock absorber inside the muscle cell. Every time a healthy muscle contracts, dystrophin stabilizes the cell membrane, preventing it from tearing under the stress.
And in Duchenne.
In Duchenne muscular dystrophy, that shock absorber is completely absent.
So every time the child moves, they are tearing their own muscle cells.
Precisely. With every contraction, the cell membranes rupture. Calcium leaks into the cell, destroying the muscle fibers from the inside out. The body tries to heal the damage, but eventually the dead muscle tissue is simply replaced by useless fat and fibrous scar tissue.
I saw a physical assessment term related to this. Gower's sign. What does that actually look like in practice?
Gower's sign is a profound mechanical compensation. The muscle destruction in Duchenne starts in the proximal lower extremities, the heavy lifting muscles of the thighs and hips. If you ask a 4-year-old boy with Duchenne to stand up from a sitting position on the floor, he cannot just push off his legs. His thighs are too weak.
So how does he stand?
Instead, he rolls onto his stomach, pushes his rear end up so he's on his hands and feet, and then literally has to walk his hands backward up his own shins and thighs, using his arms to physically push his torso upright.
They walk up their own legs. That is devastating.
Literally, yes.
And because it is progressive, it moves from the legs to the arms and eventually the chest.
Which leads to the ultimate fatal complication, respiratory failure. When the progressive destruction reaches the diaphragm and the intercostal muscles of the rib cage, the child loses the physical strength to expand their lungs or cough forcefully enough to clear secretions. Nursing care inevitably shifts to intense respiratory support and end-of-life care planning.
It is incredibly heavy. To close out this section, I want to look at one more chronic condition.
Yeah.
Juvenile idiopathic arthritis, or JIA. This is an autoimmune disease where the body attacks its own joints, causing severe inflammation. Hold on. If a joint is actively inflamed, swollen, and hot to the touch, making the child move, it feels practically cruel. Are we supposed to just push through the pain?
This raises an important question because it directly contradicts how we treat an acute fracture. With a broken bone, immobilization is the cure. With JIA, immobilization is the enemy.
It is totally counterintuitive. The natural instinct is bed rest.
It is, but if you allow a JIA patient to remain perfectly still because it hurts, the severe inflammation inside that immobile joint will rapidly lay down thick fibrous tissue.
And then what?
The joint will fuse, creating a permanent contracture and total loss of function. So you aren't pushing through agonizing pain blindly, but the nursing priority is absolutely to keep them moving.
How do you do that without hurting them?
You mitigate the discomfort first, using warm baths or heated paraffin wax dips to loosen the joint stiffness, and then you encourage full range of motion exercises.
And here's a fantastic therapeutic intervention from the study guide.
Yeah.
Do not do everything for the child just because they're moving slowly.
Yeah.
Give them extra time for their activities of daily living.
Yes.
Giving a child with JIA an extra 20 minutes to button their own shirt in the morning isn't just nice. The act of buttoning is literally preserving the mobility of their finger joints.
Exactly. Preserving independence and mobility is the highest goal in chronic pediatric care.
So what does this all mean? We started with the rapid biological 3D printer healing of pediatric fractures and the terrifying mechanics of compartment syndrome.
Right.
We explored congenital issues, understanding why a displaced hip causes extra skin folds, and how defective collagen turns the whites of the eyes blue.
And we navigated the misfiring signals of chronic conditions, from the exposed nerves of spina bifida to the missing shock absorbers in muscular dystrophy.
Exactly. Passing your ATI exam is important, But mastering these mechanisms is about becoming the kind of sharp, observant nurse who understands the deep physiological why behind the care you provide.
The knowledge becomes the tool you use to protect them. And before we go, I want to leave you with a final thought to ponder.
Okay, let's hear it.
We talked early on about how pediatric bones are so pliable they can bend 45 degrees.
Right, the plastic deformation.
Yeah. And how a condition like leg calf perthes can cause a hip bone to literally crumble while only producing a mild, painless limp.
Yeah, that was wild.
It makes you wonder, as adults, when we complain of mysterious knee pain, an uneven gait, or a chronic ache in our back, how much of our adult musculoskeletal misery is actually the ghost of an undocumented, perfectly healed childhood microfracture?
Oh, wow.
Or perhaps a very mild, completely missed congenital dysplasia that our pliable pediatric bodies simply bent around and adapted to decades ago.
That is wild to think about.
Right.
We're all just walking around with the hidden history of our childhood falls written into our bones.
Exactly.
Good luck on your ATI exam. You have absolutely got this. Thank you for bringing these incredible pediatric mechanisms to the deep dive.